All right, I hope this works. It's a different way of doing it. It's on YouTube Live, but I'm going to go over gas exchange. I know you guys have a quiz today, so I'm hoping that I can get this to you before your quiz starts. So I'm going to talk, I'm going to have, I think like 3 or 4 different videos of little ones, but I'm going to start with gas exchange and then like a pneumothorax. So I'm not sure what you guys covered in class from my rubric, that what I saw, you guys did mostly gas exchange PowerPoint this time, and then this next week you're going to do kidney. But we all know how oxygen is gathered in our lungs, and then it goes from our lungs into our smaller alveoli, and then it goes into our bloodstream. So our bloodstream, and this is a really good picture to show you is how intricate it is with all of our lung tissue, and that's where gas exchange happens. So in the capillaries and the alveoli, they are super, super like connected. So your CO2 goes from your bloodstream to your lungs, and then oxygen goes from lungs to bloodstream, and that is where that crossover happens. So risk factors for impaired gas exchange. So think of like if you don't have enough carriers and you're anemic, you're not going to be able to get that oxygen to your red blood cells to be carried throughout. So anemia, if you have like decreased surface space, so if you're like an older adult, your lungs kind of like, they don't get like smaller, but they have less elasticity. Same with like little kids, they don't have a huge lung field, so it can be harder for them to exchange that gas. Older adults, we talked about. Impaired risk, so if you're a tobacco use, if you live in an area with a lot of air pollution, chronic diseases, immunosuppressants, chemo, lupus, those kind of patients are at high risk as well. So chest anatomy, this is a really good slide for you to look at. So you have your peritoneal and your visceral linings on your lungs. So in between, so you can have different things go wrong in both, but I'm going to talk about your visceral and your peritoneal. But your peritoneal has 10 mLs in between those two layers. So if you have more than 10 mLs, then it's abnormal. You have a lot more, it's a lot more fluid there. The 10 mLs is basically there to like lubricate the two, because if they were stuck together and they rubbed against each other when you like breathed, then it would cause a lot of friction and then it would hurt a lot. So if you have like no mLs in there, then you lost all your fluid and it's not lubricating it. If you have too much, then it's going to be like inflamed, because you're supposed to have 10 mLs and now you have like 50 mLs, and that's too much, and it's going to like put pressure. Normally it's a negative pressure between these two when your lungs are expanded. So things that can affect this is like pleural effusion is fluid overload. So when you have too much fluid in that space, it can be from like smoking, or if it's like leaking from somewhere. Trauma, car accidents, stabbings, if you insert a central line, you can poke any of that. CF, cystic fibrosis, have a lot of extra secretion production. Those kind of patients you're going to want to watch out for to see how their lungs are reacting. So pneumothorax is a shift in your lung. So here's a good slide for you to look at. So see how your lungs are, and then there's this huge gap here. So there's differences between like pneumothorax, hemothorax. Pneumothorax is air that's not supposed to be in there, and it shifts that lung to the inner side. So if you have a pneumothorax on, this is my right side, but I think it's your left, I'm not sure. If I have all this air in my lung is going to shift towards the middle. So it's a tracheal shift to the opposite side. And it's going to cause pain, poor perfusion, shortness of breath, decreased level of consciousness, decreased O2 level, and decreased BP. Pneumothorax is the open air. Its air enters the pleural space from trauma, or it can be spontaneous. The normal entry wound, and it causes air to get in there, or it can be closed, which is called tension pneumothorax. So air enters the pleural space but cannot escape. So if you have a bullet hole or a stab wound and it lets air into your lungs and your lung shifts towards the other side and there's all this air here, there's still an opening for that air to kind of come back out. Tension, there's no place for that air to come out of. So it seriously is so much tension built up in there because that air is like pressing so hard against your lung. Air enters the pleural space but cannot escape. So it is life-threatening. This one is much more intense than a pneumothorax. Pneumothorax is always like very stressful, but attention is a lot more severe. So with each inspiration, the additional air accumulates in that pleural space, and then it rapidly increases that interthoracic pressure, and that makes your lung collapse. So it's life-threatening, compresses the vessels and the heart. So imagine if you have all this like air that every time you breathe in, more air comes and more air comes. Your heart's like trying to pump as much as it can, but it's not as free as it used to be, and it's getting a lot more pressure against it. You're going to have decreased venous return, decreased cardiac output because it's so tight it can't expand and contract as well, and decreased BP. You're also going to have short of breath, increased respirations, chest pain, decreased air movement or breath sounds. So when you listen, you're not going to hear any breath sounds over that air. When you listen to like the part that does have still like your lung fields there, it's a lot of pressure, but you can still hear lung sounds over your lungs. And then underlined is tracheal shift. So again, if you have a lot of air in your right side and it's pressing everything else this way, it's going to shift to the opposite side that it's on. Okay, and then pleural effusion. So when you have, this is important, these three here you're going to want to know. So accumulation of fluid within the pleural space. So it can be transudate, which is clear, exudate, which is cloudy. So those two, she'll probably ask you, I think, somewhere on the exam. It's on there. You're going to want to know the difference between those. So 90% of chronic heart failure patients have the clear exudate that's in the pleural effusion. It's fluid overload, so it backs up into your lungs, and then you get a pleural effusion, and it's 90%. And then your cloudy exudate is because of something like in an inflammatory process, infection. And then underlying, there's, I don't know if you can read. And then hemothorax is blood, hemothorax. So you have a pneumothorax, which is air, hemothorax, which is filling up with blood. Blood is pooling in your lung fields. So your lung like shifts up, and where that diaphragm hits, right above that diaphragm, like this picture, there's all this blood. So that's usually from like trauma. Okay. Potential causes. So like we said, trauma, chest trauma, blunt, like an airbag deployment. If it like hits you really hard, it can cause like a tension pneumo, like it has nowhere to escape. You're trying to breathe, but air is filling up. Or a sharp stabbing gun wound, stuff like that. Gunshot wound, sorry. CPR can cause this because you're putting so much pressure, and like you're hearing that like intercostal cartilage crack. But just imagine like all that trauma that's happening to your chest while you're trying to get that heart pumping again, you can cause a pneumothorax. This is also a good one. So mechanical ventilation. So when you intubate someone, or they're trached, depends. So it's like a CPAP. They use it for like people who, snore a lot at night or stuff like that. But you can use it like a CPAP machine, and it's a positive airflow pressure into your lungs. And all that extra pressure that you're not used to taking breaths normally for yourself, it's positively trying to force air in there, can cause a pneumothorax as well. Altitude changes, spontaneous. They don't know why it's happening. There's no warning signs. It's usually tall, young men who like work out, who are runners. They always get spontaneous pneumothoraxes, and no one knows why, but that's your demographic of people who is spontaneous, is young, tall men, usually like runners. Commonly seen in COPD, smokers, or young men. So pleural effusion, that was pneumothorax. That's what a pneumothorax can cause, or can cause a pneumothorax. Pleural effusion is, we talked about your underlying diseases like heart failure, because you have fluid overload. Capillary changes in the pressure or permeability, imbalances of the pressures That's like, and then it has bulleted under it like transdue date, that like that clear fluid that fills up because the pressures are uneven. And then decreased lymphatic clearance. So your lymph system, you have all these little axillaries here, and that's where it usually pools back up to. And if you're not clearing your system regularly of like your lymph system, it can start to pool into your lungs. Heart failure and infection. So I also have here decreased protein is albumin. And if you have a decreased albumin, you have a higher risk of malnutrition. So when you have your pleural effusions and you have all that extra fluid, like in that fluid, you can also have like your proteins. She won't really ask you too much about it. I just wrote it down because she said, if you have a decreased amount of protein, which is your albumin, you have a higher risk for malnutrition. Just keep it in the back of your mind. Okay, so signs and symptoms. We talked kind of about this. Dyspnea, so you're going to have shortness of breath, a cough, chest pain. When you listen, when you do your assessment and you listen over the lung sounds, you're going to hear like, oh, over here, like their full lung is expanded and I can hear all breath sounds. Over here, it's going to be no breath sounds. You're not going to hear anything because your lung collapsed and there's air over there. Increased heart rate, decreased BP, kind of like in shock. Your heart rate, your BP, you can't pump as effectively because the pressure is so high that your heart's going to try and pump a lot to try and compensate, kind of like in shock. Increased respiration, decreased O2 because you don't have your full lungs and like all of your lung fields anymore to have that O2 exchange. So your O2 is going to go down. Tracheal shift to the unaffected side, like we talked about. I have all this air over here. It's creating so much pressure that my tracheal shift is going to go to this side. Unequal chest expansion. They don't have their lung over here is not expanding. You could hear like a friction rub or a pleural or like a friction rub. Could mean that it's another like audible friction rub. You're having so much air or fluid that when it expands, it's rubbing against each other. That's what it means. So diagnosis of imaging. So you can do a chest x-ray, a CT, and then an MRI ultrasound. So listen to this. An chest x-ray detects 175 to 200 mLs of fluid. So like we said before, in your peritoneal, visceral, pleural space, you should have 10 mLs between the two. So if a chest x-ray can detect 175 to up to 200, sure, if you're like a chronic heart failure patient who has so much fluid overload and that is what is a lot of in between those spaces, you can do a chest x-ray. But a CT shows 10 mLs. So a CT is going to be much more indicative. Like they can tell, like even if you have like 12 mLs, like you're 2 over, they can see that because it can detect 10 mLs. So the normal and then up to however much you have in your chest. But a chest x-ray can only do like the higher amounts. And then MRI ultrasound can also be what you use. Treatment depends on the severity. If it's a small pneumothorax, they might just try and stabilize you and then observation. But if it's a lot, they're probably going to do some more. We'll talk about it in a minute. But if it's a small one, less than 15%, then they'll stabilize you and do observations. Aspiration of air with small bore needle. So they can stick a needle in your lung fields and then just like let the needle go and then all the air will pop out. Not pop out, but like here's my chest wall. They stick a needle in and then they like screw off the cap and the air will just like come out of that needle. Not necessarily hooking it up to suction or anything, just the air will come out of the needle. So I'll talk about that in my next video about chest tubes, but you're gonna want that pressure hooked up. That way suction can take all that air out. Treat the underlying cause. Why did it happen? Is there a stab wound, a gunshot wound? Can you fix whatever's underlying cause is happening? That way it doesn't keep affecting that lung. Thoracentesis effusion. So they can like take that needle again and then like take out that fluid, or if it's air, they can let the air like kind of like drain out. Follow up. So you're going to do a chest x-ray. until it's resolved. So every day you're going to get a chest x-ray until they know that you either have, like, unless that lung fully re-expands, or if it's getting better, you'll get a chest x-ray every day. Long-term treatment. So this says procedure that causes membranes around the lungs to stick together. So you can do, like, if it's something that is chronic and it keeps happening, there's treatment that you can do, but she really won't ask too much about that. So I'm going to talk about chest tubes in my next video.